Hi, everyone. I'm really excited to be joining you all today. We're going to be talking about bacterial meningitis. Alrighty, so for our learning objectives, you all will be expected to describe the presentation and transmission of bacterial meningitis, determine the bacterial etiologies based upon the age group, evaluate and determine the CSF analysis, identify antibiotics utilized, determine pharmacological and then pharmacokinetic and pharmacodynamic parameters, design a treatment regimen, identify non-antibiotic medications, determine appropriate monitoring parameters, develop appropriate prophylaxis regimens, and then finally recommend appropriate vaccinations for various patient populations against pathogens that can cause meningitis. So just a brief overview, meningitis is inflammation of the meningeal layers encasing the central nervous system. So our meninges, they provide a protection over our brain and over our spinal cord. So in the event that bacteria infiltrate this normally sterile space, then we can have inflammation. And this is ultimately something that we do not want because we want our brain and our spinal cord to remain protected. So that's why meningitis is bad and something that we try to overcome. So bacterial meningitis can be either community acquired or healthcare acquired or healthcare associated, so nosocomial. So with community acquired, we know that for meningitis, the organisms that cause meningitis include, and we'll talk about this more, but strep pneumo, H influenza B, or HIB, and then we have N meningitis. So with that being said, there are vaccines that prevent the transmission of these organisms. So in the event that people are not vaccinated against these, then we can see the community-acquired bacterial meningitis. So those will be the organisms that we most likely see. So those three that I listed in the case of community-acquired bacterial meningitis, majority of the time. For healthcare associated, though, this can happen in the event of neurosurgery or trauma of the brain. And in the event that this happens, then there can be bacteria that may be there in surgery, so different gram-negative pathogens and things of that sort, or different skin pathogens, so staph. When you see these odd pathogens that are not the ones previously mentioned, then it's likely because there was some type of trauma, some type of neurosurgery that introduced these to the meningeal space. So community-acquired bacterial meningitis has an annual incidence in adults of about 2 cases per 100,000 people. So cases have decreased, and this is because of vaccinations. I told you all that there are specific organisms that are typically present in our community-acquired cases, and we do have vaccinations against these. So that's why the cases are not very common for community-acquired, though. For nosocomial, in the event that we have individuals that are undergoing craniotomies or have post-trauma, and that including skull fractures, you can see an increase in the amount of cases, and that's because when someone's brain is open and you're performing surgery, it's easy for bacteria to then, bacteria from that surgery to then infiltrate the meningeal space and then cause infection. Risk factors for meningitis include patients that are immunocompromised or HIV positive, patients that have patients that are organ transplant recipients, chemotherapy patients. So those that are immunocompromised, that are not able to fight off these different pathogens that can exist in these infections, so extreme ages. So those patients that are very young and very old, which you will see when we talk about different populations living in communal settings, so in jail or in colleges and dorms. If you all remember, before you went to undergrad, it was required that you all had that meningococcal vaccine. So living in close quarters with people can allow for just the transmission of those bacteria that do cause meningitis. Recently exposed to a bacterial meningitis patient, so functional or anatomic asplenia, so not having a spleen. We know that the spleen functions to remove certain encapsulated bacteria from the bloodstream. So when individuals do not have a spleen, then they're not able to do that. Therefore, those bacteria can go ahead and wreak havoc in that meningeal space. If you have a CSF fluid leak, and then tobacco smoking, which can increase the presence of strep pneumonia, which is one of those meningococcal causes. So the presentation of meningitis. So about 95% of patients are going to present with a headache, and it is going to be the absolute worst headache of their life. You'll see a fever, of course, that's indicative of infection, neck stiffness, meaning that it's hard for them to turn their necks, altered mental status. We can see nausea, vomiting, photophobia, meaning that pictures are distorted and images, the way that individuals see them, are distorted. Meningeal scenes such as the Kernick and Brzezinski. So this means this is the rigidity that can be seen oftentimes with children that have meningitis, meaning because of that inflammation, they're not able to extend their legs. They have rigidity there because of the inflammation of their spinal cord. So this is the Kernick sign. So that's severe stiffness of the hamstrings, and that can just cause that inability to go ahead and straighten the leg when the hip is flexed to 90 degrees. So if you all, for me, I was admitted to the hospital because I was having cases of very bad chronic headaches. So they did this for me. They lifted my leg, and that was to make sure that I didn't have any inflammation in my meninges, so we could rule out meningitis. And they wanted me to extend my leg to see if there was any severe sickness there, consistent with the Kernick sign. Brzezinski sign. So we talked about the neck stiffness that can exist, and once again, that's due to that inflammation of that spinal cord. And so you will test to see if that patient's, if the patient is able to lift their neck up. And if they aren't, then we attribute it to potential neck stiffness due to meningitis. So bacterial etiologies. So in patients that are less than 1 month old, we can see strep acalactae, we can see gram-negative rods, we can see listeria. So we can see listeria, and this is why in pregnant women, we often tell them do not eat cold cut meats, because listeria is a bacteria that can often be present in those cold cuts. So if you have a baby and they pass through that vaginal canal, then they can also contract that listeria should a mother have it. They are not yet protected against listeria. So when we talk about bacteria, this is kind of taking you guys back to thinking about just microbiology. Bacteria exist in certain places, and in certain places, they're going to be more virulent and they're going to be able to cause infection there. So strep species as listed here, listeria, and Neisseria meningitidis, these different bacteria, they can cause infection in that meningeal space. So that means that when they see the meninges, they say, okay, this is a home for us. We can go ahead and wreak havoc. So that's why these are the common pathogens that we'll see. So when we get to 1 to 23 months, we kind of lose that listeria. At that point, the baby is able to be protected by listeria exposure from the mother, meaning that they then get the mother's antibodies and protection that the mother may have against listeria. But we may see strep pneumonia here. We could potentially see meningitis or Neisseria meningitidis. We can see strep acalactae. We can see, and then other gram-negative bacilli. We can see H. influ and then E. coli. And then as we go to 2 years to 50 years old, we can see strep pneumoniae and then Neisseria meningitidis. These will be our most likely pathogens. And as I talked about previously, and one thing that I want you guys to remember is that with strep pneumonia and meningitis, we do have vaccines against these, meaning that these are vaccine preventable pathogens. Same with that H. influ, vaccine preventable pathogens. Remember to keep that in mind. And then for the patient group greater than 50 years old, we start to see the introduction of the H. influ. We start to see that reintroduction of the listeria. And that's often because individuals or patients do not have the same protection that they may have had previously. As we get older, our bodies need to be reminded that we've seen different pathogens, or we may lose certain immunities. So keep that in mind for when we get to treatment regimens. So transmission of bacterial meningitis, just how are different pathogens transmitted to the meninges. So mothers can pass the bacteria to their babies during birth for group B strep, for E. coli. And then with listeria, this can also be passed to the babies during that birth canal, but we'll focus on how listeria is listed here. And then for HN-flu and strep pneumonia, this can be spread through the coughing and sneezing while in close contact with others. For meningitis, this can be spread by the respiratory or throat secretions, which is why oftentimes, not so 100% of the time before you go to college, it is mandated that you receive that meningococcal vaccine, because as we get older, this is just our normal progression. You end up in that close contact, or you may end up so close contact living together. Oftentimes these dormitories have double bedding, or meaning that two people live in one setting. And then we often see a lot of the exchange of respiratory secretions. So that's why we want to say, make sure your child is vaccinated before they go on to college, so that you don't have that case of meningitis due to this. With Staphylococci species, we will see this in terms of penetrating head wound trauma, or spinal cord surgery or complications. At that point, we can see staph species, so it's easy to introduce those skin pathogens there. And then for gram-negative ROS and then Listeria, this can be spread by eating contaminated foods. So as I said prior to this, with Listeria, that's why we tell pregnant women not to eat cold cuts, or because it's easy for those to become contaminated, or for those that have Listeria present. We will often tell them to refrain from that, so that they don't spread to the babies during that birthing time. So in terms of Listeria, know that it can be spread from contaminated foods. Alrighty, so for laboratory diagnoses, we want to make sure that we collect our blood cultures first. We want to do a lumbar puncture first. You want to do a lumbar puncture first. Lumbar puncture, blood cultures, you want to do those first. I'm saying that repeatedly because I want you all to remember that lumbar puncture and blood cultures need to be first. You then do a head CT scan. This is indicated in those patients that are immunocompromised. If they've had a recent seizure, you want to make sure you do a CT scan. You also want to do a collection of that CSF gram stain, which you will get after you do that lumbar puncture. You also want to culture the you also want to get a culture of the CSF fluid. You want to see if it's positive for bacterial growth. And then you also want to measure that opening pressure during the lumbar puncture. So that will be measured with the tool that's utilized to do that lumbar puncture. A greater opening pressure is indicative of meningitis. And then you also want to measure that lactate in the event that it is greater than 4.0. In acute meningitis, and it is likely to be a bacterial etiology. That's because bacteria do. We know that when that bacteria require that lactate or that oxygen, requires oxygen to go ahead and continue to be virulent. So at that point in which lactate is present, that we know that there is definitely a bacterial process taking place. So we also want to make sure that we know the typical adult CSF profile in meningitis. So normal presentation of the CSF profile is here. So we see just different blood glucose to blood ratios, and then we see the glucose that's present, protein, all of that, white blood cells. We can see when it's normal, we clearly don't have very many white blood cells. The opening pressure is between 60 and 200, but I told you all that in that CSF profile, when that opening pressure is greater than 250 or a large number, then we can say that it's indicative of infection. When the white blood cells are acutely elevated here, when we see an increase in neutrophils, we know neutrophils are indicative of infection. We see an increase in protein, and then a decline in glucose, and that's because bacteria require glucose to go ahead and continue their virulence. So when we see that decrease, we know that the bacteria is utilizing that glucose to go ahead and cause the meningitis. And then we see a decline, of course, in that glucose and serum blood ratio. That's because now that the bacteria causing the meningitis is occupying that glucose, so we see a decline in the serum. So when you see this low ratio, then we know our antennas are up for bacterial meningitis. Of course, with viral meningitis, we will not see that lower ratio. We will see a normal glucose. We'll see a normal to slightly increased protein, and then so on and so forth. So it's a clear difference there. We see the neutrophils. When we see that decline in that ratio, we know that we are leaning more into that bacterial meningitis space. So strong indicators, meaning that when you see these things, these are definitely ringing the alarm on bacterial meningitis. So a CSF glucose that's less than 34, a glucose ratio less than 0.23. I know you all saw less than 0.4 there. So at that point, that's suspecting meningitis. At this point, it's pretty much indicative. So less than 0.23, you can say, okay, this is likely bacterial meningitis more than it is not. So when we see that protein that's about 220 or greater, when we see that leukocyte count that's increased, but really when we see that neutrophil count, because we know neutrophils are indicative of bacteria, are indicative of bacterial infections. That's what we look for bacterial infection, the neutrophils. So when we see a high number in a neutrophil count, then we can say, okay, this is likely a bacterial etiology for this meningitis. So empiric treatment regimens, how are we going to go ahead and how are we going to treat these this infection? So we talked about the common pathogens there. So for less than 1 month old, we're going to use ampicillin plus cefotaxime or ampicillin plus an aminoglycoside. With the ampicillin plus cefotaxime, we're really worried about our strep here, and we're really worried about our listeria, and ampicillin plus cefotaxime have been shown to occupy those penicillin binding proteins in listeria and to go ahead and allow for us to overcome listeria infections there. So that's why we can utilize that combination. And that's what you want to consider in patients that are less than 1 month old. When we move to 1 to 23 months old, we know that we're worried about the strep pneumoniae. We're worried about the meningitis. We have the strep agalactiae, and then we have the HM flu and E. coli. So we can use empirically vancomycin, and we're adding in that cephalosporin. So I want to be abundantly clear here. This cephalosporin we could reasonably use the cephalosporin as monotherapy. The reason that we do not is because there is cephalosporin resistance, or beta-lactams do not adequately penetrate the CSF. And we'll talk about this more. Or it's hard for them to really move across those meninges and then resolve the infection there. So with that being said, and we can see higher MICs or higher minimum inhibitory concentrations. So when you see this higher minimum inhibitory concentration, and this is specifically in strep, we want to add on vancomycin, right? Because we know that vancomycin has activity against gram-positive pathogens. So when we add on empirically that vancomycin plus ceftriaxone, we're potentially able to go ahead and overcome those higher MICs in strep with that vanc plus the ceftriaxone or cefotaxime. And then we are also able to cover adequately the meningitis that may be there with that cephalosporin. So keep that in mind. The vancomycin is not there to solely cover for the strep pneumo, it's there to assist the beta-lactam. So in 2 to 50 years old, we are once again here with our vancomycin plus our 3rd generation cephalosporin. So we can use vancomycin plus ceftriaxone or cefotaxime. And that is what we would do there for the reasons as previously explained. And then in individuals that are greater than 50 years old, we can use vancomycin plus our ceftriaxone or cefotaxime plus the ampicillin. We're going to add that ampicillin back in for that reasoning that we previously described. For listeria, we do need a bit more coverage of the penicillin binding proteins to make sure we adequately occupy them and are able to overcome the listeria. It can be hard to treat. So then we will reintroduce the ampicillin there to make sure that we are adequately able to cover for that. Remember, I told you all that as we get older, our body forgets that it's seen immunity or it has seen protection against from our mothers or as we were birthed. from that listeria pathogen. So we have to go ahead and make sure that we are empirically treating for its potential presence at greater than 50 years old. So empirically, empirically for those patients that may have healthcare associated meningitis, and this being for a penetrating head trauma, post-neurosurgery, if they have a CSF shunt, meaning that they've had maybe a stroke and then they need to then redirect the blood flow. It is easy at this point to introduce gram-negative pathogens. So we want to make sure that we're covering for those staph pathogens that we talked about with the head trauma that can exist, as well as our gram-negative pathogens. So we can use vancomycin because we talked about the fact that vancomycin can cover for our gram-positives, including MRSA, should that be present, plus cefepime, or we can use vancomycin plus ceftazidime, so we can interchange those cephalosporins. Or if we are really worried about resistance, we can think about vancomycin plus meropenem. But we can also give dexamethasone. There's a lot of controversy here with this being given as adjunctive therapy. Nevertheless, you can do it. So it needs to be given prior to or at the same time as the antibiotics. You do not want to give this afterwards. You want to make sure that you really want to make sure that you're giving this at the exact same time as we are giving these antibiotics. So the adjunctive therapy has been shown to potentially improve outcomes by reducing the reactive meningeal inflammation and the neurological sequelae related to antibiotic-induced bacterialysis. Systemic dexamethasone decreases or trend toward decreased mortality and neurological sequelae. So benefits of the dexamethasone are more pronounced in those patients that have strep pneumoniae. So at the point in which it is definitively determined that the patient has strep pneumoniae, then we can continue on that dexamethasone. In the event that it is not strep pneumoniae, you find out that it's meningitis, and you stop the dexamethasone because it has not been shown to provide any type of benefit in the other types of meningitis infections. So to sum this up, you will typically give this just empirically in all patients. You will say, okay, we have this patient that has meningitis. We are going to empirically treat them with the vanc. Let's say that they're between 2 to 50 years old. We're going to empirically treat them with the vancomycin. We're going to add on ceftriaxone, and we're going to add on dexamethasone because we know that the causative pathogens can either be strep pneumoniae or it can be meningitis. We know this. So about 1 to 2 days, we get that CSF culture back, and they say, hey, it is meningitis that is causing this. And we immediately say, okay, stop the we're going to immediately say, okay, stop the dexamethasone, stop the vancomycin. We're stopping the vancomycin because it is not covered for gram-negative pathogens. We know meningitis is gram-negative. And then we're going to stop the dexamethasone because it is not strep pneumoniae. And we know that the dexamethasone has only been shown to be beneficial against strep pneumoniae infections. That's how you do that. Okay, so as I told you all, antibiotics and different drugs that are utilized in various presentations of meningitis, they have varying degrees of penetration into the CSF. So fluoroquinolones, trimethylprim sulfamethoxazole, metronidazole, they have good penetration into the CSF, but they may not necessarily be the best drugs to utilize against specific pathogens. Just maybe they don't offer the best coverage. Maybe they have a lot of collateral damage. And then we have drugs that are good for the meninges only when they're inflamed. So that's why when I talk to you all about utilizing this steroid, that's why we want to be very careful with the steroid, because if we were to give that steroid after the fact, so after the patient has already received the antibiotics, then we run that risk of the antibiotics not being able to penetrate into that CSF because we have decreased the inflammation. So vancomycin is one of those drugs that only works well in inflamed meninges. So that means we want to be very careful about how it is that we time the receipt or the delivery of those steroids so that we can maintain that ability for those drugs to penetrate the meninges. And then we see beta-lactams, they have that poor penetration into the CSF. So that means that we end up in this place where we have to really, really maximize the pharmacokinetics and the pharmacodynamics of our beta-lactams. So despite that low penetration into the CNS, there has been successful documentation of data with beta-lactams when they have been compared to other classes. So that means that we have to increase our dosing or just maximize our PK/PD to ensure that we're going to get the biggest bang for our buck with this beta-lactam therapy. So ceftriaxone, it works adequately against strep pneumoniae. It works adequately against meningitis, H-influ. We know H-influ and meningitis are both gram negatives. And then it also works against different other gram negatives that may potentially be causative, but it works against all of our really big bugs that are causative of our meningitis, of our typical meningitis presentation. Ceftriaxone does that well. So with the ceftriaxone, we often have to increase the interval of dosing with the ceftriaxone, and we also increase the dosing. That means that we'll give 2 grams every 12 hours. This is kind of what we utilize as we say our high dose, or for me, I say the meningitis dosing of ceftriaxone. So I'm maximizing the pharmacokinetics and the pharmacodynamics so that I can try to get the most penetration into that CNS. So as I told you all before, vancomycin is added solely for strep pneumoniae meningitis as additional agent to provide coverage in the presence of ceftriaxone resistance. So as I said previously, we do see higher MICs and meningitis caused by strep pneumoniae. Therefore, we tack on vancomycin to make sure that the vancomycin can cover those strep pneumoniae pathogens that have the higher MIC. So we keep the vancomycin and the ceftriaxone on in that case. So our treatment algorithm, so the patient comes, they have suspected meningitis. So the symptoms, meaning that they have the worst headache in their life, they have a fever, they have the rigidity. We then go ahead and we get the blood cultures, we perform a lumbar puncture. And then if that lumbar puncture is consistent with bacterial meningitis, we are going to start our antibiotics plus the dexamethasone at the same time. The antibiotics is going to be listed here for you all on your right. And then for our cultures, once we get that those culture susceptibilities back within that 1 to 2 days, we will then streamline our therapy, and then we'll determine our need for dexamethasone, meaning that if it continues to be strep pneumoniae, then we will continue utilizing our dexamethasone. Alrighty, so for our definitive therapy, so in the event that it is strep pneumoniae, then we want to make sure that we are looking at the MICs. Remember, I told you for strep pneumoniae, there are higher MICs to penicillins, 1, and then there are higher MICs to the cephalosporins. So for strep pneumoniae, you could de-escalate. Remember, we talked about how penicillin is our drug of choice for strep pathogens. We talked about that with SSTIs. So we can go ahead and we can, in the event that penicillin MIC is less than 0.1, then we can say, okay, let's go ahead. We can use the penicillin. In the event that the penicillin MIC is 0.1 to 1.0, then we want to go and use a 3rd generation cephalosporin. We don't want to use the penicillin in this case. And in the event that MIC is greater than or equal to 2.0, then we'll say, okay, let's use the vancomycin plus the 3rd generation cephalosporin. In the event that you get a ceftriaxone or a cefotaxime MIC greater than 1.0, then we will go ahead and use the vancomycin plus the 3rd generation cephalosporin. For in meningitis, we will go ahead and we can use either the penicillin definitively, and if we have an MIC that is 0.1 to 1.0, then we want to use the 3rd generation cephalosporin. And then if it's listeria, then we can go and we can use ampicillin definitively. If it's strep agalactidae, then we can use ampicillin definitively. So you just want to look at that. But as I said, for in terms of the vancomycin, do you continue to see vancomycin for the N meningitis? No, you do not, because vancomycin does not provide coverage against N meningitis. Vancomycin does not provide coverage. And meningitis is a gram-negative pathogen. Penicillin can work there. That is a place where it can work. But in the event that that penicillin MIC is high, then we want to go to our third generation cephalosporin. So make sure that you're looking at what break point do I want to use each of these drugs. And then with the Pseudomonas, of course, with these gram negatives, then we will go and we will de-escalate accordingly. With Pseudomonas, we know that we can use cefepime, ceftazidime, and so on and so forth, as listed here, which you all know we've seen these drugs many times before. And this is just our antibiotic dosing. This is our total daily dose that you all see here on the right. So make sure that you all are keeping this in mind when you are evaluating treatment regimens, the total daily dose that can be given. But we will talk about this more in class with examples. So based on the microorganism, this is our treatment duration. In the event that it is meningitis that is causative, then you treat for 7 days. In the event that it is HM flu, then we treat for 7 days. For strep pneumoniae, we can treat for 10 to 14. For strep agalactiae, we can treat for 14 to 21. And then for gram-negative pathogens, we'll treat for 21 days. And then listeria, we will go ahead and treat for greater than or equal to 21 days. So monitoring parameters, we want to make sure that we continue to look at our white blood cell count. We want to look at our fever. We want to look at the mental status, the headache, photophobia, and this should improve with the use of the antibiotics. In the event that it doesn't, then we know we want to escalate, or we want to figure out what else may be going on there. We want to repeat the lumbar puncture. In the event that patients do not improve with the antibiotics, patients should improve the antibiotics. So typically the lumbar puncture is not repeated, but if they don't improve, then you can. So if the response to the antibiotic therapy does not occur within 48 hours, then then at that point we will repeat the lumbar puncture as well as the CSF analysis, because we may have some type of resistant pathogen there or something. For patients with repeatedly positive cultures, we want to make sure that therapy continues for 10 to 14 days following that last positive culture. So that means that if a patient has a positive culture on so they have one positive culture, and then 2 days later they have another positive culture, 4 days later they have another positive culture, 6 days later they have a negative culture, then you say, okay, let's start counting from then. Okie dokie. So only for HN flu or meningitis will we give them the chemo prophylaxis. And what chemo prophylaxis is to try to prevent the transmission of the meningitis infection to other people within the close contact or within the household. So for HN flu, we can give the rifampin, but we're only going to give that for 4 days. For meningitis, we can give rifampin as well, and then we are only going to give it for 2 days. So for HN flu, we treat for 2 additional days versus the meningitis. But these are the only organisms in which we will go ahead and give chemo prophylaxis. So rifampin and ciprofloxacin are contraindicated in pregnant women and women that have allergies against these drugs for whatever reason, which is rare, but really in pregnant women. And in the event that they cannot take these, then you can go ahead and give ceftriaxone 250 milligrams intramuscularly for 1 dose. So for vaccinations, as I stated, these are vaccine preventable pathogens that are typically causative of meningitis. So we want to make sure that we promote the PCV13 vaccine. And here I just have information of when these vaccines are given. And of course, you all would have received more info from Dr. F, but I do want to make sure that we're clear these are vaccine preventable. And this is something that you want to make sure you tell your patients in the event that they have meningitis. You want to ask them if they have been vaccinated, or if you know that they have an immunosuppressing disease state or a disease state where they maybe had to have their spleen removed, that being like sickle cell, then you want to make sure that you are recommending that they be vaccinated against these pathogens. Also for HM flu, this is often given to infants and definitely in younger years of age, but if patients have not received it, then you want to make sure that you reiterate the importance of being vaccinated. And then the vaccination schedule is here. for those patients that have meningitis. And as I said, it's very much in those younger, so preteen to teenage years, and then going off to college, military recruits, people that will often be in close contact. So that is all that I have for meningitis. You all should be